What's up everyone, it's Hunter back with another reaction video. For those that are new here, my name is Hunter Peterson. I am a first year emergency medicine resident in Minnesota, and we're going to be reacting to episode 4 of The PITT. Again, these are all, I'm learning this, and I appreciate any constructive feedback in the comments. I think we've got the audio figured out for this one, so editing's on point, audio's on point. Be nice. Let's get into it.
The man is in his element.
What's he doing?
An age-old ritual meant to capitalize off the unknown origins of Westbridge's current state of affairs. Whoever guesses the reason they went code black wins a pot.
Ah, interesting. We didn't do this at the VA.
Yeah.
Game?
Of course.
Now, how's this look to you?
My wager is on flooding. They're going to be down for 3 hours, and we're going to get 20 of their patients.
Put me down for flooding, 4 hours and 30 patients.
Okay. Hey, Dr. Rob, looks like you got some competition.
Yes, it would appear that I do.
All right, guys and gals, enough fun. We have people to take care of. You want to bring Langdon back from Triage for the extra hands?
No,
So what they're referring to there, from the previous episode, they were notified that another hospital was put on divert, and so they're taking bets for how long and what business that will drum up for them. And being put on divert just means that a hospital is incapable of providing the care necessary for the patients that are showing up. So when they are in divert status, all ambulances need to take patients to another facility that has the resources available. So this is a kind of like supply and demand thing where the capacity of the department is too high and they need to push patients elsewhere until they're able to better serve them.
Hi, the doctor guy told me to put this mineral oil in my eye for 20 minutes. That was 2 hours ago.
We're really busy, but we'll get to you.
Okay, when?
I will check. Listen for your name to be called.
Thanks.
Next.
This can obviously happen within a very busy emergency department, especially in this context. We're kind of practicing waiting room medicine where a patient is seen by a provider in the triage area and then sent back to the waiting room while they await labs, x-rays to come back, and even just a bed becoming available. And sometimes that can come back to bite you. And in this case, I'm guessing that this patient's eye hasn't been looked at in quite a while, and now we're going to have a much bigger problem than initially just having her eyelids or eyelashes glued together and her eye glued shut.
I heard my brother was brought here. His name is Jackson Davis.
Do you have ID?
Yes. I am his sister, Jada Davis.
I'm sorry, my friend told me that he was brought in by campus police. There was some sort of fight that broke out at his school. Is he okay? Is he here?
Don't know, hon.
Can you just tell me if he's a patient here?
I'll check, take a seat, and I'll let you know.
Okay.
What's important to note, I think that in most cases it would be pretty easy to let this family member know that their loved one is indeed a patient in the hospital, but it's a concern of HIPAA and violating patients' rights, and a patient has to consent to giving out any information, and that can include their whereabouts. And in this case, the patient was brought in kind of like pseudo in custody, and oftentimes we have kind of like a lock on those patients where no information gets out or in until kind of the legality of that patient's whereabouts and their reason for being in the hospital is settled, and we can better understand the whole situation. So sometimes even if a patient is in our department, if friends or family come calling, we simply say that we don't know their whereabouts because that patient is completely confidential and only the people involved in their care are the ones that know about that patient. That might be the case in this scenario, but I'm really not sure.
Feeling lightheaded or faint now?
It's not as bad as it was before, but my head still hurts. And now my stomach does too.
What did she eat before she took her ibuprofen?
Stop by. Breakfast is my least favorite meal of the day. It's okay to look at me.
I'm sorry. We're gonna get started with some blood tests.
I think that was the perfect scene to recognize. I mean, first of all, huge shout out to our interpreter services in the department. We serve a very diverse population in the emergency department, and there are often language barriers that need to be overcome, and that can be very difficult to do in more emergent situations. And in this case, it was an American Sign Language interpreter. It is great when we can have a in-person interpreter, especially in the case of American Sign Language, just because videos can often, lag behind and not accurately depict exactly what we're saying. So anytime that we can get a in-person interpreter is much better than when we can get like a video iPad interpreter or one over the phone. But having an interpreter, there are kind of just basic good practices, which include facing the patient and having the interpreter next to you so that you are still having the conversation with the patient, and the patient can, have their conversation with you and just have the liaison of the interpreter services be next to you, because you're not talking to the interpreter as if the interpreter is your patient. You're still talking to this person that's in front of you. So that was a good depiction of what you shouldn't do, and then kind of the correction of what you should do, because just because there's a language barrier doesn't mean that patient deserves any less of care.
Good news. Nose swab came back negative for COVID, influenza, and RSV, but a lot of other viruses can cause a cough.
Lucky me.
You can take off your mask.
Pulse ox is at 91.
Your oxygen level is down since we checked you an hour ago, and your temp is up to 102.4. Let's get you some Tylenol.
Have you been outside today? It's already stifling.
Could be heat related, but we're gonna take you back to the big ER for full evaluation.
Can't you just write me a prescription for some medicine? I'm sure it's just a summer cold.
Got somewhere to be?
Work. I know, it's Saturday. I don't think I've had a day off since...
Well, your holiday weekend starts now.
I also wanted to preface this video and this whole reaction with that I have been up for a very long time. I went to the gym at 4:30 this morning and just worked a 12-hour shift on the labor and delivery unit. As a resident, we do rotations in other departments, as seen in the show here. So I did want to preface that if I miss things in the show, it's probably just because my mind isn't completely there. But I think that in this scenario, I might have missed if she had a cough or whether she was short of breath, but the main thing that I got out of this was that this is a patient who has probably some sort of infection because her O2 sats are low and she has a fever. And so the fact that he told her that she can take off her mask just because she didn't test positive for COVID, flu, or RSV was kind of weird, because everything else is also contagious. And so if a person has some sort of respiratory illness, it is good practice to have them wear a mask, not only for your protection, but everyone else in the department and those that may interact with her. So it was kind of interesting that they did that, but it'll be interesting to see what ends up happening with this patient.
You only turned 21 once.
It's your birthday? Oh, that makes you a Cancer, right?
I didn't peg you for an astrology girly.
I'm a Cancer.
Yeah, I've been spending too much time around Santos.
Dr. Santos, making progress on your charting, I hope.
Getting there. Deficient charts leave a gap for the providers who give continuity of care and delays hospital billing.
Oh, I'd hate to delay billing.
Timely documentation is essential. Let's fix this before end of shift.
I'm on it, boss.
Good.
It's super common that we get kind of like messages from billers and coders or reprimanded by staff for not having our charts done, because in emergency medicine, it's pretty important that our notes are finished before we leave, because the patient is going to go off other places and people need to know, what happened, what brought them in, and our story of what that is very important, and it needs to be part of the medical record. So I think that, I forget this doctor's name, but if she would have phrased it and framed it differently, it could have motivated Dr. Santos to get her charts done in a more efficient manner. I like to think of our notes as asynchronous communication with other providers, and I take pride in having very good, thorough notes, but in a succinct way that's nice to read, because people don't have all day to read paragraphs on every patient. But along with asynchronous communication, it is important for hospitals to be able to bill, because when insurance does cover things and we do bill for it, it's how the system works to be able to pay for those that can't afford it and are on lesser insurance or no insurance at all. And so it is a very frustrating part of medicine, but as EM providers, we kind of are sheltered a little bit from what insurance and things do, because we just provide whatever care is necessary. But I think it's a really important part of residency to learn exactly how that system works, so that you can have a better understanding of exactly what you're doing for patients, what you're writing in their notes, and how that affects their care moving forward.
Pamela Perry, 48, abdominal pain with vomiting after eating chilaquiles with fried eggs. BP 108/64, pulse 98, good sats.
Who do we have here?
Jean Samba, 54, half an hour of left-sided chest pain, history of hypertension on lisinopril and Crestor. Some relief with 2 nitro, decent vitals, no STEMI on 12 lead, gave him 324 chewable aspirin.
And who do we have here?
Vince Cole, 23, fell through the skylight of a florist shop, then beat down to a bunch of ferns, complained of headache, asking repetitive questions, and only response to pain.
Multiple lacks in the glass, BP 118/72, pulse 98, sats 99 on 5 liters, no meds, no allergies.
Hey, Vince, how'd you fall through a skylight? Vince, were you with him?
Yeah, we were parkouring and he overshot a con ball.
But like jumping off of buildings, people still do that?
It's almost an Olympic sport.
Now we know why it isn't. Pupils are equal and reactive.
What do you got?
Yeah, 10-foot fall, altered.
That's a long way down.
10 feet is the threshold for trauma center activation. 10 feet, 10% mortality.
0%. Anything over 0% is a concern.
Somebody's annoying and it's not me.
Hey, you said 2. You missed one.
Sent you back up, didn't I?
1, 2, 3.
Thanks, guys. Good to see you.
I don't know how long this case is going to last, so I wanted to jump in and say that those 3 reports from the medics were like perfect. It was just enough information that you know kind of exactly what's going on with the patient. You got all of the pertinent information, like some past medical history, meds, allergies, vital signs, as well as any interventions that they did en route. Those were picture perfect. I mean, it took 20 seconds and you have a pretty good picture of what's going on, and then you can kind of take it from there by talking with the patient and getting your workup started.
Pulse ox 99, heart rate 102, blood pressure 114/78.
And EFAS is negative.
Music to my ears. Somebody shooting a documentary here?
EFAS negative, so I don't know if we've covered it in a previous video, but a FAST exam is a ultrasound exam that looks for free fluid within the abdomen. So the ultrasound probe is used in a few different spots to look for where fluid commonly accumulates, and this is done in pretty much every trauma activation because they want to know whether this patient is unstable and needs to go right to the OR because they have free fluid or likely blood in their abdomen somewhere, or if it doesn't have anything and they're looking more stable, they can go to the CT scanner to find out exactly what the extent of their injuries are before going anywhere like the OR or an ICU.
Yeah. Hey, Jesse? Do you think you could repeat this, but with the chest leads on his back?
Why?
T waves are kind of high with ST depression anterior.
We see ST depression all the time.
Yeah, but could be a posterior MI.
All right, run it by the attending. If they agree, we'll do it.
Thank you. Victoria, if his CT's normal,
I think that kind of illustrates how sometimes there's a hierarchy within a department. So Whitaker is an intern, and this very seasoned nurse didn't really want to do exactly what Whitaker wanted. And I think if Whitaker feels strongly that this is a possible posterior STEMI, which does present as a very difficult EKG finding sometimes, he should have advocated stronger for this patient, because this is still an emergency. This patient probably needs to go to the cath lab for emergent intervention, and by delaying this to get the okay from the attending, I'm guessing that there's probably going to be some adverse outcome that had he pressed harder or the nurse had just trusted him, that would have led to a different outcome. And that's not to say that there is like a hierarchy, like nurses have to listen to doctors. There's great checks and balances here where often nurses catch simple mistakes or even big mistakes that doctors are about to make, just because nurses are oftentimes dealing with fewer patients than what the doctors are. And so they are the ones doing the care directly to the patient and can catch these things before they become problems. And so there are often times when nurses will come to me and say, are you sure you want to do this? Or should we do this instead? These attendings usually do this. And like, I am super thankful for all the feedback from my nurses, but sometimes I feel very strongly about the decisions I'm making and press back and, kind of insist that we need to do it the way that I am verbalizing that we need to do it because the patient's safety is at risk. And I think that this is one of those cases.
This is Jada Davis, Jackson's sister.
Oh, thank you. Hi.
Is he okay? And why is he asleep?
He was uncooperative when he first arrived and needed to be sedated.
Uncooperative? That doesn't make any sense. What happened?
We're still trying to piece the story together. He was brought in by a campus security guard who tased him after he was allegedly combative and violent.
Wait, what do you mean tased him?
We've treated his injury, and now we're trying to understand why he was so agitated.
Okay, this doesn't sound like my brother.
Well, his drug screen came back negative, so now we're taking Jackson to get a CT scan of his brain to look for any abnormalities.
Can I go with him?
You can't go into the CT, but you can wait for him to come back, and then we can discuss next steps.
Okay.
I think this would be a great opportunity for one of those doctors to stay back with, I believe she said that she was his sister, to get more collateral information, because clearly she feels that he's not acting like his normal self, and there might be a lot more history that they could gather from her that might shed some light on what exactly is going on.
Otter, get here.
You fell at your construction site. A coworker brought you in.
He's a lot better, but doesn't remember anything.
That's common after a concussion or DKA.
DKA?
It's a serious complication of your husband's diabetes.
How serious? Can he go home?
We still have to clear the ketones from his bloodstream. He'll need to be on an insulin drip for a while until things get back to normal. Best if he stays in the hospital.
It's okay, Mom.
Things are headed in the right direction, Mrs. Diaz. He's going to be better.
Sorry, I gotta check his blood sugar.
Oh, do you mind? Absolutely. So, the thing is, we don't have health insurance. So, I don't think that we can afford this.
I'll have our case manager, Noel Hastings, come by. She's an expert in health insurance. She might have some options for you for coverage.
Okay, thank you.
Unfortunately, that is the case in a lot of the patients that we see. Some patients will delay seeking care because they don't have health insurance and don't feel that they would be able to afford whatever treatment is necessary. And oftentimes that leads to patients waiting until things get even worse and end up in a very bad situation, sometimes even in the ICU. And we always have case managers available, at least in our department, to kind of navigate these situations to make sure that patients are able to navigate the financial side of their healthcare after leaving the emergency department. We're also seeing a lot of patients that will, like in the case of diabetes, ration their insulin because they can't afford it, and then that still leads to very similar problems. So, healthcare costs in America, they are astronomical. I don't know what to do about them. Something needs to change. And I think that shows like this, bringing it to light to everyone, is very helpful.
I'm tired.
Yeah, as soon as we're done here.
Whitaker, Louis on them, his tooth is ready for you.
That's great. Hey, I'm having some trouble here with adherence.
Oh, of course you are. Try this.
Yeah, that makes sense. You think you could... Do you mind if I paint some sticky stuff on you?
If you must prolong the inevitable, so be it.
You'll get to lie down afterwards.
And so right there was a case where Perla, a very seasoned nurse, had a trick that was helpful to the intern in the department. So, having a good relationship between the nursing staff and the physicians is always better for patient care and just for morale in general.
Hi, Miss Ronson. Felicia, please. Felicia. I'm Dr. King. This is my colleague, Dr. Santos. What brings you in today?
I've had this pretty bad cough for a few days now.
Do you smoke? Are you coughing up anything? Any chest pain?
No, and no. I honestly think I picked it up at work. It was going around.
Where do you work?
I'm in corporate at PNC Bank.
Step forward, please.
It could be an office bug.
Or I got it from the gym. I'm there all the time.
Do you have anything to ask, Dr. Santos? What? Do you have any questions to ask our patient?
No, I'm good.
Okay, what'd you hear?
Maybe some crackles at the right base.
Okay, well, we're gonna need a chest x-ray to check your lungs.
Will that take long? Maybe I can still make it to the office.
That shouldn't. You can go put the orders in?
There were kind of some weird vibes in that interaction, but I think this illustrates how we can often get kind of like laser focused on the more common diagnoses, and it's important to keep a very broad differential in the emergency department. This person could have any sort of just like viral illness, but I mean, in the summertime, it's like less likely. I'd be wanting to know more questions, like if anyone else around her was sick, if she engages in any, high risk environments like in jails or homeless populations, or if she has done any travel recently to, endemic areas where they have things like tuberculosis. She might have hobbies like spelunking in caves and be at risk for something like a histoplasmosis. So there are a few other questions that they should be asking to kind of delve further into her history on top of getting the chest x-ray. I think that's very appropriate.
Your brother should be back shortly. There was a little holdup at CT.
Should I be worried?
Let's wait and see what his test results say.
This just doesn't make any sense. It doesn't sound like my brother at all. He's the friendliest guy I know. He never even gets angry, barely yells.
He's never had an episode like this in the past?
No, or not that I know of. He's in a great relationship, and he's in law school because he wants to help people. He always tells me that I should follow my dreams, even if it means my parents may disown me. Should I call them?
I think that's a good idea. This could be pretty serious. Thanks.
The new radiologist is a hottie.
His head CT is normal, as are his blood and urine tests.
Then what's wrong with him?
We're not sure yet. There is another test, a spinal tap. So this could be an infection in the fluid that surrounds the brain, viral encephalitis. It can also cause altered mental status and confusion.
Can you treat it, if it is?
Yes.
Okay.
Two things here. One, we never get our results back as soon as the patient is wheeled back from the radiology suite. Like, it's usually patient gets an order for a CT, then they wait for a period of time. Sometimes it's an hour, sometimes it's 2 minutes. They go back to CT and get the image taken, and then they come back to their room, and it takes another 45 minutes to an hour for a radiologist to read that, and then we have the results. Now, we look at image results ourselves and take a look at them, but we don't make any definitive decisions based on our own reads simply because we're not radiologists. I mean, there are big things that we catch and know exactly what to do when we see them, but for the more intricate findings of some CTs and MRIs for that matter, we wait for the radiologist to read them, which can be hours. And the second thing, it's interesting to see Javadi has now changed her tone after she's learned that this patient is a law student who is not typically agitated. She's now using more formal terms like altered mental status and confusion.
How's it going over here?
Better now.
Oh, the x-ray is back on your foot. And no fracture. So, ACE wrap, ice, rest, and elevate, and you can take ibuprofen if you need it.
So that's it?
Well, if it's too painful to bear weight, we can give you crutches to use for a day or two.
So I won't be seeing you again?
As a patient, no, but it was nice meeting you, Brian.
It was nice meeting you too, Dr. McKay.
I was gonna go check out a few of the art galleries in Lawrenceville tonight.
Have you been to that one on 40th and Butler?
No, I was gonna go by maybe around 9.
Okay. Cool.
I think that these interactions are more common than I wish that they were in the department. It's just like very frequent that we have patients that are very inappropriate, and this was very inappropriate behavior by her because there is clearly a power differential in this relationship with a doctor and patient, and it is just never appropriate to be in any sort of relationship with your patients. So will this come back to bite her? We'll find out, I guess.
Louis, this is a temporary fix, okay? You're gonna need to get that tooth pulled by a dentist.
Hey, you gonna find me one?
We can have you talk to Dylan.
Is Dr. Collins around? My sister always helps me out.
Dr. Collins finished her residency. Took up a job in Portland as an attending physician.
Portland?
Yeah, I think that's where she's from. She's adopting a baby. Wanted to be closer to her family.
Wow, that's a beautiful thing.
Okay, ready?
They should be wearing some sort of eye protection, probably face protection as well. Anytime that I am doing pretty much any procedure, I want my face covered because it is way too common in the ED that there are fluids of all types spraying places that they shouldn't be going.
Hi. You called for a consult on Jackson Davis?
Yes, we did. I'll let Victoria present the case.
This is Jada, Jackson's sister. This is Dr. Jefferson from Psychiatry.
Psychiatry? Do you think this is a mental health problem?
We thought it best to cover all our bases.
We'll know more once I speak with your brother.
Okay.
Hi, Jackson. Jackson, can you wake up? Jackson.
They said he's sedated.
I'll come back a little later.
Oh, that was fast.
Yeah, next time, maybe wait until the patient wakes up before calling me down. Psychiatrists do best when we can actually talk to our patients.
I got a little ahead of myself. Will do. Thank you. Sorry.
It's another one of the difficulties of working in emergency medicine is that oftentimes we might have a plan and know exactly where a patient needs to go or who needs to see them, and the timing just isn't right. In this case, I do think that, again, the psychiatrist could have gotten some information from the sister at the bedside, but he is right. I mean, talking with the patient would be ideal, and completing their workup would also be helpful with their LP.
Who's the genius who pulled that out?
I thought it was a loose fragment.
Next time, leave the decisions to the adults.
Okay, Dick. Okay, ready to go? Whoa.
Ooh, looks like an icicle.
Christmas in July.
Hey, Sophie, can you answer that?
Okay, I am injecting the X-Stat.
Hello?
What is that?
It's a syringe filled with tiny rapid expanding hemostatic sponges.
Okay, got it, thanks. Radiology attending says a resident missed something. There's a radiopaque foreign body in the left paralumbar musculature.
Not anymore.
Sounds like first week in July syndrome.
Mm-hmm.
Okay.
So what he was referring to there with the first week in July is that is when all of the new residents start. So interns, like myself, start on July 1st doing our first clinical duties as doctors. And the joke is kind of that you never want to be a patient in the hospital in July because you have all of these inexperienced doctors taking care of you. But it really is just a joke because even though we are inexperienced and learning, we do have many levels of seniority above us that are supervising us and making sure that we're learning how to take care of patients properly. Now, mistakes like this do happen, but they're very uncommon and they typically don't lead to issues like this. But it is very important when mistakes are made that we own up to those mistakes, are honest with families, and are empathetic with the whole situation and what happened, because you don't want to break that patient physician relationship and make your patients not trust you because you're hiding information or even lying to them. That's just not okay either. So it'll be interesting to see kind of how this plays out.
Must be lady.
Mm-hmm. Okay, first I need to get a good grip for the reduction.
Uh-huh.
Here we go. Try to relax. Deep breath with your mouth open.
Not how I imagined our first intimate encounter.
Okay. Got it. Now on 3. Okay? 1.
Motherfucker! Oh, you son of a...
I know. Sorry, it keeps you from tensing up. Okay, I think that worked. How does it feel?
Can I sit up?
Uh-huh.
Oh. Oh. Oh my God. Oh. It's definitely better. Oh my God.
Great.
Can I give you a hug?
Maybe later. Okay?
It's probably not very obvious what exactly just happened, so I would like to put a little thing up on the screen here, which is a pelvis with a spine. You got a sacrum and a coccyx. He had a fracture of the coccyx at the sacrum, and it had a little bit of anterior displacement. And so by putting a finger in the rectum, she was able to hook onto the coccyx that was anterior and then shove it back so that it was in alignment with the sacrum where it's supposed to be. That would be incredibly painful.
And I just want to say, I think it's great that you're in the Physicians Health Program. I know it's a big commitment.
Yeah, it was hard at the beginning, but I'm almost done with year 1 now. Only 4 more years to go.
Penny for your thoughts.
Oh, they're way more expensive than that.
I'm on a budget. Take it or leave it.
My day is not turning out the way that I expected.
We had a call out. Langdon was available.
I was sort of hoping to be on my sabbatical when you came back.
You two were very close. Maybe this is the universe's way of telling you it's time to clear the air.
Maybe it is. Maybe it isn't.
I think it's always a bummer in these shows where you don't get to see, what happened between last season and this season, whether there was more to it or whether, sending Langdon home was just the last time that they saw each other before now. But this is a relationship that you hope that can come back together in the end.
Yo, what's up? I got a bounce back. You remember Debbie Cohen?
Not really. I've seen 16 patients this morning.
The restaurant worker with cellulitis on the dorsum of the foot?
Yes, she's on Caflex. I marked orders.
Yeah, I got a hot pack on it, but you should take a look.
Hi, Dr. Langdon.
I wasn't expecting to see you back so soon. Meds upset your stomach?
No. The pain got worse, and you said to come back if the redness spread outside the Sharpie line.
Let's take a look. It looks like the infection isn't responding to the pills I prescribed you, so we need to get you on some IV antibiotics and get you back to the ED now.
Is it bad?
Not if we can get a handle on it. Worse? Or maybe worse.
That is a very common practice in the emergency department, that we will draw a line around rashes to see if they are spreading or getting better. And that's super helpful because they might end up going to a different emergency department, and then they can see what we saw when we saw them at the time that we saw the patient. I would want to know a little bit more about this patient. Like, I'd probably be getting some labs, which they'll probably do in the next episode when they get her back in the main department. But besides just like a rapidly spreading cellulitis, I would be concerned for like a necrotizing soft tissue infection. She might need like a CT of her leg to see if there's any gas from bacteria in it, and maybe even get a surgical consult. But when something is spreading this rapidly, there's no way that an oral antibiotic would be able to act fast enough, and she needs IV antibiotics right away. That was a pretty good episode. I feel like there was less for me to comment on that one. I'm also just like fried in the brain, so we'll see what the next one brings. But we'll catch you for episode 5 next week.